me, I mean, I'm 35, very close to 36. You do an X-ray on my back, you're probably gonna see.
I won't let him do it. I won't let him do it. I know.
No, you don't want to know.
Exactly.
You don't want to know.
Ignorance is bliss in many
it's
things.
Better to
In
not
many
know.
things, ignorance is bliss.
So then, if we look at the shoulders, since that's what we want to talk about today, it's something like 96% of people over the age of 35 will have some sort of degeneration issue.
Absolutely.
And if they're athletes, it's probably 100%.
Well, I was talking with Jake Peters yesterday about it, and
he's going through his.
Well, he's had shoulder issues forever, and he works out smart most of the time.
He told me he overpressed like 185% of 5.
Oh, he's a strong guy. Yeah, he's a strong guy, and but heavy in athletics, right?
Yeah.
His job, I mean, really, his only job in his adult life has been as a trainer.
Oh, okay.
To my knowledge, I could be misquoting. I don't think he did anything significant. Yeah, me too. I mean, really, me too. You know.
Okay.
And so he hasn't been sitting down for a majority of his adult life. You know, standing up, right? But because he was so active in athletics, you know, overuse. And when you're young, it's kind of like you're like a pit bull, right? Dogs are tough. They don't feel pain. When you're young, you're tough. You're dumb. And you don't feel pain.
Right.
So he's paying for it now. I'm paying for it now. Yeah. But then on the inverse, you have those people who've been super underactive for years.
They still have the same.
They still have very similar issues.
Right. They may just be asymptomatic.
Exactly. They get asymptomatic until they start wanting to be a little more active, right? Or somebody maybe threw a ball 1,000 times, has some rotator cuff, or maybe someone's had a computer desk for the whole life, has some rotator cuff issues.
Right.
So
do we
have get started? We don't have to wait for anybody. Yeah, I'll get this man. I was thinking
it's just a small
right here
deal or whatever, but I mean, we don't need it, but.
Well, not moving here, but move this. He's over here. Hey, Renee. So, no, it's all good. She's just waiting. So, with Zoom, setting up the meeting, especially when it's here, really, really easy. You're going to have a prompt, click on it, sign in. Right now, sign in is me, and all that stuff automatically in there. But then you see up here, we have a waiting room.
Oh, nice.
And so she'll pop in. And again, we had 4 or 5 people signed up, but the nice thing about this is I'm recording here too. But what's up, Renee? But what will happen, and the reason I'm recording with this as well, is so I can more easily upload this to YouTube, and then we can share it via the app. But Nathan's working on, so we're doing these, and I think I have mute on entry. I know, cool, she can talk. These will automatically upload to YouTube, and they'll go into a list, and then we can then have a library of stuff like this. Renee, how are you doing?
Good, how are you?
I'm doing well. You actually have some shoulder issues, right? If I remember correctly?
Yep.
Yeah.
Just got an injection about a week and a half ago.
Turkey shot or cortisone?
Cortisone.
How's it feeling?
Feels a lot better. If I could feel comfortable with doing some activity without injuring it, I'd probably be better.
Is your backhand game still strong with your husband?
Yeah, no.
That's the goal of today, is to get your backhand game strong.
Yeah.
We've got a couple more people signed up. We'll wait. They might pop on. They might not. We'll do it either way. I'm going to get a couple things cleared, and we'll go from there. Okay, Renee?
Okay.
But I can do things. hop off the webcam and I can kind of follow.
Oh yeah, that'll work.
Small dumbbells. They're all little dumbbells, but they're a lot.
You smell pretty good.
What's that?
You want a little help? Or?
They're all little, so like in my mind.
Yeah.
All right, I decided this is rocket. There's us and Renee today. Renee, though, I am going to mute you until the end, just in case you have any questions, and you'll be able to ask some questions. And if we don't know the answer, we'll make them up like we're the president of the United States. Okay? Okay, I wouldn't really, probably should have made that joke. I probably should have made that joke. We are recording. But it's funny, you know? It's funny. It's,
Just edit that out.
and I can't edit it out. It's on the internet forever.
Okay.
All right. Okay, so Renee, you know who I am. Anybody else watching this video, my name's Logan. I'm director of fitness here at Fit Club. I've been a personal trainer actually since I was 19. I'm 34 now. I've done a lot of things wrong. Have created a lot of issues with myself. But as I've gotten older, as I've gotten more experienced, I am learning now to correct them. To my right is Mike Purdy, master trainer, one of the, if not the best of us here. What, Mike, some of these guys know you, just give a slight background.
Background, okay, so started working here in 2008, and then went on, while I was working here, I went on and got, earned my bachelor's from Millikan in exercise science, and then right after that went to SIUE for the master's program in kines there, and just been training here ever since.
And you're an adjunct professor at Millikan.
Yeah.
So he's smart. He's really smart.
Wow. No.
And so what we're wanting to do with these segments is a little bit of everything, okay? We know, and we were just kind of talking earlier, almost everybody has some issues, whether they know it or not. So today what we want to do is address one of those issues, one of those dysfunctions, and understand we're going to take a look at some things. We are not doctors. We are not making diagnoses. We are simply making some observations and maybe helping you correct, maybe helping your body, your shoulder actually feel a little bit better. Because generally when there's some ache, when there's some pain, there absolutely might be some injury. We'll talk about, you know, when to know, hey, this is an injury over this is just an ache or a strain. But oftentimes it's very fixable with things you have at home. And so those are what we want to address today. So Mike, you know, in your experience, you have a ton of clients now. You've worked with a ton of people over shoulder issues, pretty common, right?
Yeah, I mean, we were just talking about this earlier. So, and again, infotainment purposes only here. We're not diagnosing anything. So, anyway,
I like that.
Yeah. Oh, I stole that from someone else, so I don't remember who.
Ours
so
now.
It's yeah. So really interesting if you do X-ray or MRI on people's, well, we were talking about lower back, but then also shoulder too. Something like over, I can't remember the exact percentage. It's like it's over 90% of people over the age of 35 are going to have some sort of issue if that can be seen on X-ray or MRI. Now they may not feel any pain whatsoever or have any apparent issue, but it seems to be just part of the human condition. Now there are some reasons for why that may be. Think about the shoulder. So what's the great thing about the shoulder joint? Well,
backhand husband.
You could, well, I wasn't going to go with that. Sure, but you do that. But you can do basically anything with it, right? It is the joint in the body where you can do pretty much every single movement, as far as anatomical movement goes. However, that's somewhat sacrificed by joint stability. So much of the joint stability, if you look at, okay, what kind of joint the shoulder joint is, it's ball and socket joint. But if you compare that to, say, the ball and socket joint that's your hip, that is much deeper and actually in what's called acetabulum. So if you're looking at if this is the femur, and this is the head of that femur, so that actually fits in quite nicely for the hip. Nice. When you're looking at the shoulder, so the humerus, so this bone right here, the upper arm bone, when that looks into what's called the glenoid fossa that's on the scapula, which is the shoulder blade, so back here, it's a very sort of narrow, this is what's called the true, often called the true shoulder. If this is the head of that humerus, it's just a very sort of shallow, I guess a shallow ball and side joint. So the good news is that I can do, all this movement with it, but unfortunately that sacrifices the stability of the joint. Fortunately, there's a lot of big muscle mass, well, via smaller muscles and then bigger muscles too, that help to secure that. But that's sort of the trade-off that we have.
So what keeps the shoulder in the socket?
Oh, well, yeah. Again, well, if you look at this, so if you feel right here, so your clavicle or your collarbone, if you start here, so the sternoclavicular joint.
Big word.
I don't want to turn this into a boring anatomy,
but that's okay.
a boring anatomy lesson. But if you follow that up, and then you're going to feel a little kind of bony ridge right here. So that's your AC joint, your acromion-clavicular joint. That is the acromion is one of the processes off of your scapula, the shoulder blade. So this is the point where that is actually attached. So the scapula is actually attached to the rest of the skeleton. It's through this. And again, we're talking about joints that are, they're not particularly strong joints. All right, but again, it allows us to be able to do a lot of movement. So that's what you have right there. And then you have that glenoid fossa that's on the scapula where the humerus is going to connect it to. So you have the ligaments through there, and then you also have muscle too. So what are the muscles that are helping out here? Well, you have the rotator cuff muscles, so your supraspinatus, infraspinatus, teres minor, and then the subscapularis. You also have the trapezius, so really big. Yeah, here, let's go like this. There you go. So big diamond-shaped muscle, trapezius right here. Those are also attaching in through that, basically that spine on the scapula there. So you have a lot of big, and then the rhomboids too. So now these are deeper. So if you tear away Logan's traps, which sounds horrible, but if you tear that away, underneath there you have strong muscles called the rhomboids, rhomboid minor and major. Those also attach to. So you have a lot of muscle mass that is helping to do that. But again, it's not like a set socket like the hip joint is. So we do have some. Again, the ligaments that create the joint, and then a lot of muscle mass that helps to provide stability. But there you go.
Muscle and cartilage, basically protecting that shallow joint. So that stuff's squishy. That stuff's squishy. That stuff injures pretty easy. So what are some common causes of injury?
Well, I mean, again, so it can just be sort of a classic thing. Can potentially be overuse. So if you think about professions where they have to do like a lot of overhead, think like electricians or something like that. Those are usually something that you may see.
Drawing
a lot
blood.
of throwing. If you're talking about sports, a lot of times you hear it in throwing athletes. But again, what we talked about earlier is over 35. So what happens as we get older, sadly, is, arthritis can develop. And then if we're talking about arthritis, then we're also talking about potentially like little bony spurs that may happen on that bony anatomy. If we think about, again, that spacing between the head of the humerus as it fits into that glenoid fossa, and then we have that acromion clavicular joint right there. Well, in between there you have muscle. Right, so the big ones being the supraspinatus, not the big ones, but the smaller ones, the rotator cuff being supraspinatus and infraspinatus. Side note, the supraspinatus is the most likely one to get injured, or the most common injured of the rotator cuff muscles. So if you have arthritis that is developing around there, which is just something that happens with age, sadly, and then you start having like little bone spurs that may happen, because of the way that that bony anatomy can butt up against each other, you almost have, and if you have bone spurs, it might be like almost like a sawing action on those muscles. So again, one of the risky ones being the supraspinatus, mostly that one because that's the one that's most commonly injured. So that can be something.
Yeah. Well, and so remember too, each muscle has a purpose, right? And then the shoulder, up, down, in, out. So you said the supraspinatus?
That's the one that's technically, so that's an abductor is one of the ones that are going there.
So And a lot of times I see I have clients with pain, they're fine here, they're fine here. A lot of times they're fine up here, but it's when they get to
right.
And I'm one of those guys, right there, not necessarily pain, but there's a catch.
Yeah,
there's some restriction there, right? So are there any tests that they can do?
That one would be the empty can test, is kind of the one they talk about. So it's like you're dumping out, you're emptying the cans, typically thumb pointing down, and there's a little bit of a slight diagonal in through here, so that when you lift up like that, or you adduct, if you may feel a little twinges come up, because again, and I wish I had like a skeleton or whatever.
I will take off my clothes.
But if you're,
I'm just kidding.
the viewership just went enough. Yeah. So if we're looking at, again, this is the head of the humerus going into that fossa right through here, and when you abduct, so that's going like this, you potentially have that butting up and that pinching of that, again, that supraspinatus. So that's where going like this, and you may feel that's what it is. So this would be the impingement part that could happen there.
So again,
potentially.
It's an easy potentially. It's an easy thing to do. You have some issues here that might be one of the primary causes. So what are your recommendations? So let's say we have a doctor that said, hey, this is an issue, or like myself, I do have a doctor. I work with Dr. Kevin Imhoff, young gun, who, as if I doesn't like that, I call him young gun, but he's younger than his dad, so, right? And he's actually diagnosed with that exact issue.
Okay, yeah.
Okay, so let's say we have been diagnosed. What are some things that we can do? Therapy, stretches, what are some things that we can do to address?
Okay, so if we look at like what our jobs are to get people moving, exercising, getting stronger. So we need to try to find some sort of variation that allows you to be able to, whether it be overhead press or whatever it is, strengthening the muscles of the shoulder, girdle and shoulder joint. We just need to figure out some variation. What tends to help out people, so if we think about like the two big ones as far as strengthening the muscles of your shoulder. Oh yeah, there we go. All right. If we think about barbell ones, we're talking about bench press and overhead press, or you could do dumbbells. Or if we're thinking body weight exercises, it could even be something like stick-ups, where you're just doing, because again, we're kind of stuck in this world right now where limited access to equipment, sadly, or push-ups. So push-ups is a good one. So if we think about what I was highlighting earlier, if we have this kind of butting up that occurs with the abduction, so if we're trying to move the most amount of weight, say like on a bench press or a push-up, then you want to be out here, really wide grip, because of kind of the recruitment with the muscles, but also just what's advantageous here. I do from a side view where it's easier. You're keeping it right over the acting joint. But the issue with that is that if you have, if it doesn't feel good, then what a very simple fix is, so if you're doing your push-ups really wide, bring your elbows in. So you look more, so instead of being at this 90-degree angle here, you get yourself at more of a 45-degree angle, and that can potentially help out. Now, a general recommendation is the closer the grip, and typically a neutral position. So this is supinated, that's pronated, so a neutral position. That tends to be easier on the shoulder joint. So personally, I look for ways just to allow you to be able to do, so if someone has those shoulder issues, figure out ways that can allow them to still do push-ups or bench press or overhead press, whatever it is. Now, if that still doesn't work, and lightening the load, so how do you lighten the load on a push-up? Well, the first thing you do is if you're doing straight leg, you go drop down to the knees. If that's still too challenging, then you increase the hand position. So if you have just wall space, or a countertop is quite handy. You can do your push-ups like that. Yeah. That can potentially help. Focus on squeezing the shoulder blades back together, because again, you're trying to strengthen the muscles around and through that upper back. So just like that. And then coming down, and then coming back up again. So more neutrally. Now, the trade-off potentially with, if we're talking about a more neutral grip, is that tends to make the exercise more challenging. So if you think about like a wider grip push-up, and then going to a closer grip push-up, it does make the exercise more challenging. And again, that has to do with the body position and more stress being placed on the triceps. Well, it's not that the chest is still working, but tends to be doing more of the brunt is more the triceps, so smaller muscle mass, So it's gonna be harder. But if this allows us to be able to train, then I personally don't care.
Oh, absolutely. I think that's an important note here. Just because maybe a particular angle of something it doesn't feel great doesn't mean that you have to completely give up that movement.
Right.
It means we just have to find an adjustment around. So that neutral grip we're talking about, and that's easy to do. We have actually, and I see you use it a lot, that multi-grip bar, that football bar.
Yeah,
right?
yeah, if you have access to
You use
that,
it with
it's
Ray,
nice.
they have access to that, awesome. With a traditional barbell, you don't generally have the ability to do that.
No,
However, dumbbells, so let me go grab one. So dumbbells, you can still do a neutral grip, right? By keeping my palm facing my face. So we're still in that neutral grip and allows for a very similar movement to that press we're all used to. We're just changing the angle of the hand, changing the angle of the elbow. And for your push-ups too, increasing the angle. But let's say you've got the strength, right? But for whatever reason, keeping it tight here, we can actually go ahead and grip some dumbbells that are a little bit bigger, make it maybe a little bit more comfortable on your wrist, because I know a lot of people are restricted with wrist mobility too, right? So when we keep it here or here, it tends to hurt a little bit. So grabbing a couple pair of dumbbells that get your hands off the ground and gripping those, that can help as well. And those are big muscles. Those will work your compound muscles in ways that help alleviate the issue. Are there specific exercises for those smaller muscles that we can do to
So
help
some
repair?
things that you can do, like let's say that if this is something that, all right, and this is where we go back to the infotainment thing. If you're just coming off of surgery or something, I mean, that's a totally different deal as far as rehabbing stuff goes. But one of the things that you can do is you do want to start moving, because there's an adage, and you hear this a lot in the physical therapy world too, motion is lotion. So one of the worst things that you can do is just doing nothing at all. So it can be something as minor as just going through those basic, well, quote unquote, basic movements of what the shoulders do. So one of the things that you can try out, again, if we're thinking about a neutral grip, is just how, I'm going to do from the side view so you get a better view here, is shoulder fletches. Now, it's nice to do these with your back up against the wall. I don't want to mess around with camera stuff right now, but if your back is up against the wall, and then you actually push your lower back into the wall, your heels will be about 6 inches or so away from the wall, and then from there, with your upper back up against you, this is from going from here to here, is called shoulder flexion. Doing that can at least help to start getting that movement in. Now, you can regress that even further by facing the wall and kind of walking up.
So if I'm his wall,
this is going to get really creepy, right? Really quick. But okay, so yeah, you can do one of these, because again, if you're doing it like that,
I'm just gonna tickle the top of my head.
you're getting some support from the wall to help out with the shoulder if the shoulder's not feeling great. So that's something that you can do just to get and start establishing that range of motion.
So let's say somebody starts, here, and then they hit pain, like pain, sharp, stabbing, searing pain. Here, do we want them traditionally to work through it?
Well, okay, so that's
I know
depends on the person.
That's a very controversial question.
One of the things, yeah. So again, if you talk to even physical therapists, there is, again, because from that standpoint, we're almost talking about maybe it's something post-op, or maybe it's like, hey, they might have to actually get an operation at this point. It won't be pain-free. Again, infotainment purposes. But generally, it won't be pain-free. You may have to. Now, if it's so much to where it feels like someone has just jabbed a knife in there, I hate to use that analogy, twisting around and doing everything like that, then yeah, you're probably going too far, too fast. If you're right here and you start walking up, and then like you said, it's like you typically maybe like right around there, start feeling
Flinch a little
that
bit.
might be it. That's fine. Walk it back down, and then just keep gradually going up and see if you can get further up. If that doesn't work, then other things may need to be addressed or done.
See a doctor, So what about stretching? We actually didn't have this conversation before.
Okay.
What about stretching?
Well, again, if it's something where someone just can't get, it's not even necessarily a pain thing. It's more of just, that's my best shoulder flexion right there. You maybe can do some static stretching that can help out. If you are allowed, and if that's the case, so what's the big muscle? If then it'd be your lats. So potentially you may be fairly tight through the lats. What are you going to do to stretch those out? Well, stretching the lats is shoulder flexion.
Right.
So you may, if you're starting to feel a stretching through here, then that may be what's going on. Now, what's the easiest way to do that? If you have a stability ball, that's what you're doing here right now.
Yeah.
Okay, so even if you have a chair,
and most people have a chair,
it can be done. And more of a, well, you start off in a quadruped position, if I still okay. And
that means on your hands and knees for us normal people.
You kind of slide forward a little bit, and you should start to feel a stretch there and through the lats. So that can potentially be useful to do to stretch that out. But it may just be that those muscles just need to get stronger, or, and again, I hate to say this if we're coming on, I mean, if you are in your late 70s and you have more of a kyphotic posture, and this is your best shoulder flexion, I mean, there's probably no exercise that's going to really be able to
increase that range of motion.
Somehow get you from here to
absolutely
here. You just got to work around with the best that you can
exactly.
do.
And I think that's the key when you get to that point is you still find things to work. And that was your point before.
Yeah.
We can work around it, right? You can always find things to work around it. If it generally hurts, be aware, understand what pain is okay. Because with the shoulder, a lot of times you do have to grit through some pain. I've dealt with people with frozen shoulder before, and you got to break through it to break through it, right? And that is not a comfortable process. But if you don't use it, you lose it. So it's important to find things that you can do to still work the muscle, to still work the tendons, ligaments, and the joints.
Yeah, frozen shoulders are really weird. They don't really, newer information, they just don't really know why.
No, it's
how it's occurring. So it's
and it just is, and it's breakthrough. And what happens? Well, it happens after surgery, or after you lack of using it.
Yeah, right.
Your shoulder just basically gets stuck, and you got to burst through the wall, right? Super uncomfortable. So a couple of things that you can take away from there. If you do have some shoulder issues, make sure you're still working within the realm that you are comfortable and able. Make sure that you are stretching. I think lats are one of the biggest and most common things that get tight and lead to shoulder pain, and stretching those lats. Foam rolling, are you a big foam rolling guy?
Well, with foam rolling, it's a little bit more superficial, so it's...
Oh, we might argue.
Now, it's not. I'm not saying that. Well, obviously, if you foam roll something, you will certainly feel that the roller, particularly if it's one of the hard ones, or those nasty medieval torture devices that have like the bumps and everything like that on them, or just using. I thought we had one around like just PVC pipe and rolling.
I actually bought one of those $7, best piece of equipment I ever bought, $7, big old thick piece of PVC.
Yeah. So that let me back up and say that if your range of motion's fine and you can do stuff, you probably don't really need to do it too much. However, I will never discount the psychological benefit of doing something.
The placebo effect.
So even if something doesn't physiologically do much, if it doesn't psychologically, hey man, the mind is a powerful thing. So
I asked this question, I've never seen a foam roll.
Keep doing it. Admittedly I did used to, but I don't anymore. So I know, strike me down.
No, it's okay.
And the fitness gods will throw a lightning bolt at me.
I think there's some evidence. At the very least, to increase circulation to the area, and if there's pain in the area, it can bring relief to pain. Right.
That's the more the physiological thing. So if Logan punches me in the arm, the gate control theory of pain. So if he punches me in the arm, I'm like, oh man, that hurt. Well, it's not like me rubbing doesn't take away the pain, it's just distracting with another sort of stimulus. So
there's a major pain quote in there somewhere.
Rolling, yeah. So foam rolling can do that, but again, I mean, it's not to say that it's totally useless. I mean, if you can feel that there, and if there's something there, I mean, give it a shot. I mean, again, if your shoulder flexion is looking like this, and you're doing static stretching for the lats, and you want to do a little bonus for it, then that
doesn't hurt.
It could be useful. Could be.
I remember with stretching too, it does take time to make significant change in soft tissue. I'm not really a big fan of the 30-second hold. I like to hold a stretch until I notice a significant difference. And oftentimes that is a little bit longer. You can't overstretch things, but then 60 seconds, 90 seconds, even that 2-minute mark, I find is a little bit more valuable than just kind of holding something for 30 seconds and then moving on.
Well, let's be honest, who's holding a stretch for 30 seconds? It's
5 seconds. It's
hardly
10
anyone. It's like, I'm going to stretch my hamstrings. Oh, yeah, yep, got that. And then go
But
on. So,
dedicate
anyway.
time to it. You know, at the beginning of your workout, at the end of the workout. You know, if you're going super heavy, then obviously static stretching will save to the end. But if you're just going through some light training, throw it at the beginning, throw it at the end, doesn't matter. I think the most important thing is that you do it, right?
Yeah, I mean, I'm never going to tell people to not do more physical
This is
activity.
him
So
trying not to argue with me. I love it.
Not even that. No, I'll never argue against someone for doing more physical activity. So no, that's always a good thing. Because yeah, again, it's the motion is lotion adage. So the more movement that you can do, generally, the better. Now, if you're doing something that is repeatedly causing the problem, then you may not want to do that. So like deliberately, you know, if you're doing that, if that empty can thing bothers you and it's like right here, it's painful, and you just keep going like this, okay, yeah, that's probably not great for it. But trying to use through a full range of motion as best as you can, that'd be good route to take.
All right, cool. Well, Mike, thank you so much. Renee, I'm going to open it up now to you if you have any questions. And then we just go over here. We hit unmute. And if it's a bigger group, we can go down here. This is kind of blocking it, but there's mute all, unmute all. So, what's up, Renee?
Hey.
You have any questions? It's cool if you don't. You just say hi.
No, I mean, pretty much everything Mike just said correlates with what my doctor was telling me. Doesn't matter what you do or anything, just you're going to have some type of damage.